For many residents listened to an incredible lecture for HIV, and I'm still buzzing from a rlrcpsolvers.com event yesterday. And the pioneer and the reason of the driver of that event is actually amongst us. Alec Razai, who you all know and love, most of you all know and love from VMR, presented one of the most incredible cases I think that's ever been put out there. We'll probably have that on the website on Monday. It was real treat to discuss your case, Alec, and not the least bit surprised that you're back here today for more clinical reasoning. So thank you. And no, the discussion was not better than the case. I don't know, Prof. Rez, if you agree or disagree with mine.
Your discussion was not mine.
Definitely not true. We're also really excited because one of our newest VMR team members, Sarah, is scribing today. Sarah, you want to say hello to the crowd?
Yeah, hi everyone. My name is Sarah. I'm a third-year UCSF medical student studying for Step 1. I've been a long-time admirer of CPS, and I'm humbled and inspired by you all. So I hope I can make this the best learning experience for you as possible.
Oh, that's so kind. And Joy is back for round 3 or 4, I think. Joy, is this how many times have you done teaching points before?
First time.
Amazing.
First time.
All right.
Yeah, I'll try my best.
No, you will do absolutely fantastic.
Not disappoint.
No chance. Disappointment is impossible. We're thrilled that another one of our dear friends, Andrew, actually has a case. And I told him that we would open it up to the crowd, but I'm rethinking that because we don't get to see you as often as we would like on Friday. So I feel like we should just take advantage of that if that's cool with you.
That sounds great. Let's do it, everybody.
Okay. All righty. Andrew, you want to say a quick hi?
Yeah. Hey, everybody. Just got back to New Haven from a trip to Boston, which I make quite frequently. Going back into my night shifts tonight. I'm covering the infectious disease and the nephrology services tonight. Although I supervise interns, so really they do the brunt of the work, but it's really great to be able to supervise them and see so many patients.
Amazing. Well, you were, I think, an excellent clinician, but an even better teacher, I would say. So people are
with even a better beard. That beard is just so
oh my gosh.
Man, I wish I had the beard. Anyway.
I feel like I don't know if Prof. Rez has shared a story publicly, but I understand your pain, Prof. Rez. I understand it.
Well, I have a very interesting case for you. Full disclosure, there is no final clear diagnosis for this, so I think that means y'all will be in for a ride. I think you're in for a good discussion though. Whenever the board is ready, we can get started.
Oh, for me it says host disabled participant screen sharing. Maybe I need to be co-host.
There you go.
Yeah.
Sorry about that.
There we go. Thank you.
Nice. Thanks for scribing, Sarah. Okay.
Yeah.
So a woman in her 40s, oops, give me 1 second. It always makes it full screen when the screen gets shared. Okay, a woman in her 40s presented to the hospital with diffuse, crampy, intermittent abdominal pain for several months duration. Regarding other GI review systems, she also has constipation and she's on Miralax for that, but no nausea, vomiting, or diarrhea. Of note, she had established care with a gastroenterologist several months ago to have these symptoms evaluated. And a CT of the abdomen with contrast performed several months prior to her admission showed multiple mildly enlarged mesenteric lymph nodes. On this admission, a repeat CT scan is performed showing, quote, hazy infiltration of the central mesentery with whirling of the central mesenteric vasculature, suggesting malrotation of volvulus. Rim-enhancing lymph nodes within the central mesentery are also visualized. And Sarah, I'll be sure to put this all in the chat for you too. I know this is a lot. Her past medical is notable for fibromyalgia and migraines. She takes omeprazole and Miralax. She's had no surgeries. She is a former smoker. She is up to date on colonoscopy, mammogram, and pap screening. And her vital signs show no fever, a normal blood pressure, normal heart rate, and a normal oxygen. And that's aliquot number 1.
Wow, Andrew. Yeah, thanks for putting it in the chat, because as you were speaking, it was hard enough for me to actually process. and appreciate all the data you were shooting. So I can only imagine what Sarah was going through. But Sarah, you did such a good job. You're typing. I would predict you type, like, tell me the truth. Do you type 70 to 80 words per minute?
Probably something like that.
All right, that's probably the only thing I'm going to diagnose correctly today. So honestly, we could, if we wanted to, spend 20 minutes on just this aliquot, but we're not going to. We're going to be realistic here. And what's realistic here is you have a 40-year-old woman with chronic abdominal pain that's described as cramping in nature, associated with some mesenteric pathology, most notably enlarged lymph nodes that are mild and what seems to be a volvulus. And when we put that frame, oftentimes with abdominal pain, when we don't find an etiology, the majority of those patients do well, the majority of them. So like when you're with your patient, and if you think about it, abdominal pain is probably one of the most common chief concerns that bring patients to the hospital or to the clinic. Even if you don't get a diagnosis, after a workup, after a thorough workup, that patient is more likely than not to have resolution of the abdominal pain. But there is a subset where the abdominal pain persists. And when you're thinking of abdominal pain that's chronic in nature, I think a very good approach is to take the approach of image positive or image negative. Now, this patient has fibromyalgia, and we know that the CNS to gut connection is real. A lot of patients with CNS disorders, whether it's psychiatric or not, will also have gastrointestinal symptoms. And it's almost like this vicious cycle where then the GI symptoms exacerbate the psychiatric or neurologic symptoms. And it's, constipation probably in this patient is related to the irritable bowel syndrome is the most common cause of constipation. And it's not a benign medical condition. It's not. Constipation sucks. And all of us have experienced it, and we know how it can affect our mood, our psyche, etc. But here, the focus really has to be the mesentery. But even there, you have to be cautious. Why? Because we don't have severely enlarged lymph nodes. We have mildly enlarged lymph nodes. But once you tell me that there's a volvulus, Andrew, my mind is thinking, what is the focal point of pathology that led to the intestines twisting on itself, right? And if this patient has true-on-true volvulus on this CT scan, first is the emergency of how do I alleviate this acute obstruction? Because you can have ischemia, perforation, and death. And then secondly, what was the lead point? Was there a polyp? Was there a mass? But here it's hard to ignore those lymph nodes. And so maybe I can now pass the mic to Robbie to continue along that discussion or add whatever else that he might want to add to that framing.
Prof. I completely agree with you. It's very, very tricky. And I think that I think the reason that I'm stuck downstream from the conversation that you were starting us with is you have to always be careful with radiology. And I think radiology, the radiology read that says clinical correlation is actually a very wise one, because many, many times something that is seen on a scan may not actually be the cause of the symptoms that the patient is facing. And I think that the thinking of diffuse crampy abdominal pain for several months and wondering, well, is the radiological finding actually account for that? And I think that's something to always hold on to. And here, I'm not 100% sure, but we can immediately tell that if we use the radiology to help us, that we're dealing with something pretty unusual. And the unusuality is that the disease seems to be centered on the mesentery, which is, just for simplicity, a collection of connective tissue that houses the vessels and tethers the bowel. That's where the disease seems to be occurring. And that disease is either primarily in the lymph nodes in that area with spillover into the connective tissue, or the disease is in the connective tissue with spillover to the lymph nodes. And I think that you're pointing out that the lymph nodes aren't pathologically or severely enlarged makes it a little bit harder to solve and makes me wonder whether the disease is actually that of of the mesentery, i.e. a connective issue, or if it's that of the lymph nodes. And I think that's the key tension. But if you were to Google or look into mesenteric diseases, I think that you would be able to generate a DDX. But where I'm at the 10,000 foot view is, I'm not so sure that this radiology is 100% slam dunk for the symptoms. So ready to not fall into that trap. I think that the lymph nodes and the torsion physiology are a sequelae of the primary mesenteric disease, inferred by the subacute nature of the symptoms and by the size of the lymphadenopathy. And so I'm centering the disease as a primary disease of the mesentery. But that is so rare and so unusual that I think the traps along the way would be, what if it's an unrelated finding? And what if we have that wrong? What if it's actually the lymph nodes that are our primary focus? So excited to see how we can dissect it, but I think that's where the spotlight is for now. All right, Andrew, tell us more, please.
I'm very excited to give you all more information. This next one, I don't think will give you a ton of progress, but just for the sake of splitting up into aliquots, I'll give you this next aliquot. We're moving on. So her exam was remarkable for diffuse abdominal tenderness with guarding. Her initial lab showed a white count of 10, a hemoglobin of 12.3, and a platelet count of 502. The BNP values were all within normal. The protein was 8.6, the albumin was 3. There was a normal T-bili, AST, ALT. The alk-phos was elevated to 219. Although she was stable, she was immediately sent for XLAP, where the surgeon commented that the mesentery looked, quote, quite thickened with some enlarged lymph nodes present. There were patchy areas of normal small bowel between distended edematous bowel. While some mesentery appeared as if it had recently twisted, it was all found not twisted and no necrotic bowel was seen. She was then discharged. That's aliquot number 2.
I think the star of the show is not Reza or I. The star of the show is Sarah, who somehow, I don't know how, is able to keep up. It's incredible. So Andrew, I appreciate your efforts to try to get a lot of information in one go, because I can see this is a complicated case. So I understand why you're moving at light speed. I'm deliberately slowing us down though to give Sarah a moment to catch up. I'll summarize the findings, and then maybe I can discuss the labs and pass on the surgical findings to Prof. Rez. So the findings that we should all just note are that there's thrombocytosis, and there's an elevated alkaline phosphatase. It's just as important, if not more important, that all the other labs are negative. And I think what's really powerfully negative is the albumin, because in somebody with abdominal pain and a potentially inflammatory disease in the GI tract, the albumin being reassuring is, well, is it 3? Andrew, did I miss that? Is it 3? So maybe not. What was the albumin again? Oh, you put it in the chat. Sorry, I always have the chat closed because my mind is
3, and the protein was 8.6.
Okay, all right. Oh, actually, that's really helpful. Sorry. So I'll summarize. Thrombocytosis, elevated alkaline phosphatase, and a protein gap. A protein gap is defined as the difference between the albumin and the total protein. And when it's greater than 4 or 4.5 here, it's unequivocally high because it's 5.6. That is defined as a protein gap. So let's just discuss those, and I'll pass the mic to Prof. Rez for the imaging. So thrombocytosis. It's tempting to think that thrombocytosis is a bone marrow problem, but that's not true. It's usually a reactive problem. And there are 2 things that platelets can react to. One is inflammation, chronic inflammation, be it from an infection, an autoimmune disease, or a malignancy. But platelets can also react to some other things. And those other things are disorders of hemoglobin. So you can actually get a thrombocytosis when you have acute anemia. When you bleed a lot or you have hemolysis, the bone marrow goes crazy in a non-specific way. You can also get it as a rebound phenomenon in patients who have thrombocytopenia from a specific suppressor, and that suppressor is gone. So for example, patients who drink alcohol, they will come in intoxicated and have low platelets. And when you get them and help them on their journey to sobriety, they'll actually have a transient rebound thrombocytosis. So anemic disorders, rebound disorders, and the most important one to think about here is hyposplenism. or functional asplenia, which again is functional asplenia that occurs usually in patients with GI issues. The most common cause of functional asplenia is sickle cell disease. And here that's not the case because the hemoglobin is normal. The second most common cause of functional asplenia in all comers is celiac disease. And a shout out to Kirtan for teaching me that recently. So I say that because we're talking a lot about GI stuff, and the platelets may reflect a GI inflammatory disorder, a GI immune disorder, or actually just an inflammatory disorder causing functional hyposplenism. The thrombocytosis, though, if we're thinking about it from the big picture, is it reactive inflammatory or reactive non-inflammatory? The presence of the protein gap suggests that it would probably be reactive and inflammatory, because the protein gap usually is a hypergammaglobulinemia, an increase in all serum immunoglobulins. There is a small chance that this immunoglobulin gap represents a monoclonal protein. But monoclonal proteins don't usually cause a thrombocytosis, with the only exception being POEMS syndrome. And this case is not showing up like POEMS in any way, shape, or form. So I'm inclined to think that the combination of the thrombocytosis and the protein gap is most suggestive of a reactive thrombocytosis. And in this patient who doesn't have marked weight loss or marked inflammatory symptoms, I think it's most in line with the possibility of an autoimmune disease. Now, what could that autoimmune disease be? I think that the mesenteric findings would have you think and consider of IgG4 disease, because IgG4 disease causes the mesenteritis that Andrew is describing. But I think you need a lot more data, including the surgical data, to help you think that through. So, summary of the labs: the patient's probably inflamed, as evidenced by the combo of the thrombocytosis and the protein gap. But the word probably is important. These are inferences, not definitive conclusions. All right, Prof. Rez, thoughts?
Absolutely. I think it's, I love the fact that they took this patient straight to the OR, because that was one of our main concerns at time point 0. And as much as we are clinical problem solvers, like, we have to force ourselves to think about treatment too. And that's the only way you'll grow in that arena. And of course, the treatment's always a bit tricky because we're not seeing the patient up front, but just based on the story, it's just nice to get that validation that they were concerned about this volvulus. And then something I have to mention is, when you're approaching abdominal pain, it can have so many possible diagnoses. But here, the cramping nature is starting to make sense, because literally, when you have cramping abdominal pain, you really think of some kind of hollow viscous being obstructed. Whether it's the bowel, whether it's the biliary tree, it's just something that's causing cramping, on, off. So it just correlates with the pathology that we found here. What I would do with this finding, honestly, Andrew, is I would say, okay, we have the swelling in the intestines, we have the enlarged lymph nodes. And I love what Robbie said about, like, the spillover is it's starting in the lymph nodes and spilling over into the GI tract, or vice versa. Oftentimes it starts in the GI tract and spills into the lymph nodes, though many diseases, lymphoma, one of the most common sites of extra lymph node lymphoma is the GI tract. So what this does for me, let's talk about the GI tract first. That bowel wall edema, the most common etiology would be what? Would be heart failure. But there's no suggestion of heart failure or congestion, and not even heart failure. I would say portal hypertension. There's no suggestion of that. And it has skip lesions. So then I convert that edematous bowel to bowel wall thickening. And when I do that, I go through my eyes of infection, inflammatory, infiltrative, and ischemic. Nothing to suggest ischemic, not really giving us the flavor of infection, to be honest. So you're left with inflammatory bowel disease and infiltration. Then I bring over the lymph nodes that are in the mesentery, and I say, okay, can IBD, specifically Crohn's, have skip lesions? Yes. Can it cause bowel wall edema? Yes. Can it cause lymphadenopathy? Yes. And so this would prompt me to ask the question, could this be IBD? And yes, the patient's not in that bimodal age distribution, but that doesn't matter. It can happen, okay? And so this would make me either pursue an MR enterography to better assess for this, or send some, fecal calprotectin and lactoferrin and all that stuff. The lack of diarrhea, remember, diarrhea, hematocrit, that stuff is more common in ulcerative colitis where you always have proctitis. Then you go into the infiltrative category, and Robbie already mentioned a few: IgG4 disease, amyloid, sarcoid, lymphoma. And this is where the platelets, I think, makes lymphoma and the lymphoma-like disorders potentially less likely. And prioritizes stuff like amyloid, sarcoid, and specifically IgG4 related disease, because the center of gravity, if it is an inflammatory disorder, is the mesentery. So it's something that has a tropism for the viscera as opposed to extra visceral organs. I'm just laughing because anyways. So bottom line is this: I don't think you can actually biopsy the bowel. Like, I don't know, like, would you cause like I have no idea. When you go endoscopically, you take the superficial, you're not like perforating it. Could you do it during surgery? I don't know. What I would do is I would take one of those lymph nodes and study it for either, a granulomatous process like sarcoid, do a Congo red stain to see if there could be amyloid, and then look for possible plasma lymphocytic infiltrate of IgG4 related disease. I would actually do that. And I'm not jumping the gun here because we're in a CPS setting. Like, this patient has been having symptoms. There's true pathology in the OR. There's skipped lesions. Let's study it. Let me just pass the mic to Robbie one more time, Andrew. And by the way, when I joke with you about Formula One, it's because I like you and I care about you. I was calling it Formula 51, but I know Robbie loves the Formula One. But anyways, Robbie, I just want you to reflect on that for a second.
Yeah, Prof. Raz, I couldn't agree more with you. And I think, I think you're 100% right in emphasizing that this is a disease centered around the mesentery. And what we're trying to make sure is that it is not a disease that is metastasized, not necessarily malignant, but this is a disease that lives elsewhere, that has gone to the mesentery. And the clues are that there's bowel involvement, that there's alk phos suggesting maybe liver involvement. And at the end of the day, I think that's the tension. Is this a disease that has gone to the mesentery, or is this an inherent disease of the mesentery? And within the inherent diseases of the mesentery, you can still have a systemic disease that has only affected the mesentery and doesn't have any systemic symptoms. But unfortunately, a large fraction of primary mesenteric diseases are idiopathic inflammatory NOS diseases that usually get better with steroids. Some people think they're a limited form of IgG4 disease. So the only thing that I would do now, having had more time to think, would be to look at some subtle clues that the patient may have IgG4 disease with the data we already have. And those subtle clues would be looking at the diff for eosinophilia and sending an SPEP, which we should send for the protein gap, because an elevated IgE is another subtle clue for IgG4 disease, in addition to, of course, the IgG4 level. So those are some simple tests that you can do that can prioritize that disorder, which is important in a subacute chronic, potentially inflammatory syndrome. So invest in the labs. You can get more out of them than we have right now, for sure.
And may I make one comment, because I think it's really important, Robbie, is that usually when you have imaging evidence of bowel wall thickening, it's not heart failure, right? Like, this is the only reason I bring up heart failure here and bowel wall. It's because it's what they saw intraoperatively, but not radiographically. So I wonder if this just wasn't enough to be seen radiographically, and there's no findings of heart failure to suggest that's causing edema that usually leads to the abdominal pain and heart failure. So it prompts me to consider infiltrative causes. I don't want you all to think when you see bowel wall thickening on imaging, you should think primarily heart. No, you should think the eyes in that context.
Wow, guys, I spoke a little too soon. I thought that alpha wasn't going to give you that much progress. I think that discussion just goes to show you can take even 2 findings and just really take the clinical presentation and go bonkers with it. It definitely going to give you some more information here to help you pivot a little bit more. And Reza, this is Formula One. That was only lap number 2. So take your deep breath. You're at the pit stop. I'll give you the information copy pasted in a second. This is a big aliquot here. Okay, so 1 month later, this is just the start of her journey. 1 month later, she represents with palpable purpura on her face, arms, and legs that were rapidly appearing and progressing in size. Her labs were roughly the same. And on new history taking, she agrees that she has night sweats 1 to 2 times per month beginning in the last couple of months. She has 1 oral erosion on the left hard palate. She does not have a history of recurrent genital or oral ulcers. Her CRP is 270. Her INR PTT are high. The fibrinogen is high at 708. The dimer is 6.74, which is high. The UA shows 16 RBCs, 2+ protein. Dermatology is consulted as short-lane admission. She has significant edema of the right hand nearby a large purpuric lesion. And they comment that her purpura appears retiform. A thrombophilia workup is negative. ANA is 1 to 40. She has negative Smith, SSA, SSB. RNP and APLS labs. A C3 and C4 are both high. She has negative ANCAs. She has negative cryos and cold agglutinins. Her RF is mildly high at 19.9. A complete gammopathy workup is negative, and a negative HBV, HCV tests are sent, and she has a negative echo and blood cultures. Let me put that all. I know it's a lot. This case is crazy.
Wow. Thanks for putting it in the chat. There's really so much to dissect here. And I think what I'll do is I'll just try my best to talk about some of the findings and then just let Robbie pick up wherever he wants and whatever he wants to focus on. And I think often in cases like this, you need to calm down. You need to calm down and step back and just list, like, what are the most salient features, and try to identify the most salient feature that you must explain by the end of this case. Otherwise, you'll get bogged down in so many findings that it'll be hard to process. And I think when I'm looking at this case, one of the most striking features now is the cutaneous findings. And it's really important to note that a lot of disease entities, there's a tempo to them, but something about tempo that we don't often discuss is whether the disease has a biphasic tempo or whether some clinical findings happen later on. For example, Whipple's disease. Oftentimes we'll present with arthralgias. Years later, you get GI symptoms, that lung, etc. So it's important to study the timeline of events. And you always have to be cautious, making sure that there wasn't a medication started that led to the findings of the subsequent clinical symptoms. So I'm going to actually, like, what really is striking is palpable purpura. Boy, you can't ignore this. And you have to explain it. So let's just do that very briefly. When you see erythematous lesions on the skin, you want to ask the question, are they blanching or not? Because if they blanch, then it's just vasodilation. It doesn't necessarily mean it's benign, but much more likely to be benign. If it doesn't blanch, it tells you that there's extravasation of red blood cells. So why do red blood cells extravasate from the blood vessel? How many of you have had a bruise before? I'm not seeing many hands raised. That's okay. I'm assuming you all are saying, yes, I've had a bruise. Oh, thank you, Joy. Thank you, Robbie. There you are, Rebecca. So basically you have trauma to the vessel, the red cells extravasate, you try to push them, but they don't blanch. That's one way you can get it. So trauma related. Another way you could get it is if you have a coagulopathy. So you have to quickly look at the INR, the PT, the PTT. How can you tell if this non-blanching rash is palpable? You close your eyes and you try to feel the contours of the rash. If you can feel the contours of the rash, you have palpable purpura. I don't know if they've ever done studies to see how sensitive that finding is, but it's a buzzword to say that the vessels are inflamed and is pretty much pathognomonic for leukocytoclastic vasculitis. So all of a sudden, this disease is involving lymph nodes, it's involving the GI tract, and now it's involving the vessel in the form of inflammation. Whenever you have inflammation of any vessel, the question is it small vessel, medium vessel, large vessel, or a variable vessel vasculitis that can involve any types of vessels. And you now wonder those skip lesions and the edema. I know we didn't see necrosis. Could there be, micro ischemia to the gut? Again, less likely, but you wonder. Meaning, is the GI findings a manifestation of vasculitis? So doing this exercise, I'm going to pass the mic to Robbie soon. I'm basically saying to myself that there is vasculitis. I'm saying to myself that there's definitely small vessel, but something is so odd here, folks. Usually vasculitis involves the legs predominantly. Why does it do that? Gravity. Anytime something involves the leg, the answer is almost always gravity. You have gravity increasing the pressure in the vessels on the legs, so you don't need as much inflammation in those small vessels to see the sequela. That's why a lot of these small vessel vascularities present with palpable purpura on the extremities. To have it on the face, and another thing Andrew said is that it's net-like, it's retiform. And net-like, you always have to be wondering about thromboses of arterioles that are now showing the network of the arteries in the form of a rash. So this is very weird. This is very weird. So if I'm going on Google, I'm like, what would cause this? So I will pass the mic to Robbie, but just to end the DDX for that, I'm thinking of small vessel vascularities, but when I think of the GPA, MPA, EGPA, and hypersensitivity vasculitis, none of those commonly leave a strong imprint on the gut. These are primarily upper respiratory, lower respiratory, and renal disease entities. The variable vessel, from IgG4-related disease to Behçet's to other processes that Robbie will remind us of, are more likely. So let me give the mic to my broski Robbie to see what he has to add to that.
Professor, I think you're fundamentally simplifying this problem for us and saying you've made it so clear why you think it's a small vessel vasculitis. And what I'm trying to do right now is honestly try to convince myself, how confident are we that we can go into a narrower frame of small vessel vasculitis plus glomerulonephritis with the hematuria and proteinuria? Because like you said, the most common cause of a small vessel vasculitis of the skin is isolated cutaneous leukocytoclastic vasculitis, diagnostic noise in a systemic case. So I think here, in the presence of the hematuria and proteinuria, along with the cutaneous findings, I think you can start to say, wait, I wonder if this patient has glomerulonephritis. And the first thing you should think of when you think glomerulonephritis is before you say it's autoimmune is to make sure that you're not dealing with endocarditis or infections like that. And we've been fooled like many times before. And you always want to be open to later learning from Andrew that the patient has a pet cat and has Bartonella. But from an operational perspective, the reason that that's much less likely is a sneaky tip for you all. Almost all infection-related vascularities are hypocomplementemic. So the normal complements here are very helpful, not just because they help you prioritize between categories of infection and autoimmune, but even within autoimmune, they help you prioritize. Essentially 2 or 3 diagnoses. Normal complementemic GN could be compatible with anti-GBM disease, but anti-GBM disease alone does not cause cutaneous findings. It is limited to lungs and kidney. So that's off as in isolation. The ANCA-associated diseases are not off. The ANCA testing is imperfect, and depending on which ANCA can be negative in up to 50% of patients. So a posse-immune glomerulonephritis with negative ANCAs is totally fair game. Of course, eGPA is not at play here because there's no eosinophilia. So MPA and GPA are fair game, but they're much less likely in the absence of a respiratory fingerprint. Unusual. I think if you start to look at this case and say, hold on, I have a normal complementemic glomerulonephritis with prominent purpura and GI manifestations, IgA vasculitis and HSP starts to come into the fold, especially when you recognize that its GI manifestations can also affect the mesentery. So for me, Prof. Rez, I think I'm starting to say, is this a glomerulonephritis? Is this a normal complementemic ANCA negative GN with GI and skin manifestations? I think the variable vessel vascularities are also really important to think about. And if we go through those systematically, lupus and RA are gone because there's no manifestations of them. IgG4 disease is definitely a very important consideration, but the major limitation is that by the time a patient has IgG4 disease vasculitis, they're also usually hypocomplementemic. So my pivot is this an HSP? Is this HSP spectrum disease or a mimicker of that?
I absolutely love that, Robbie. And just something along the line of management. The normal creatinine, I don't know if the creatinine was normal here, but the normal creatinine should not be reassuring at all, folks. That does not lessen the likelihood of a GN, and that does not lessen the possibility of giving this patient 1 gram of methylprednisolone to save the kidneys.
Yeah. Anything else, guys? Or
Oh,
perfect.
please tell us more.
Okay, perfect. Yeah, your comments on the active urine sediment are very interesting. Just an aside here, in real life, I only intersect with this patient on like one hematology consult, and everything else I've pieced together through the chart. But what I could gather is that the management of this patient and the diagnosis of this patient was challenging because the management kind of interfered with the diagnosis. So because she was having such rapid purpuric lesions, even raising the specter of like basically ischemic limbs and threat of losing, limbs, really the focus of the diagnostics ended up being on those skin lesions and then also the lymph nodes. The normal creatinine did seem to kind of reassure everybody else, and just given the skin findings and the known GI stuff, they ended up focusing their work upon that. So there's going to be no renal biopsy coming. But let me give you what was done. And because the final diagnosis remains unclear, I'll just give you the rest of the information for a final discussion. So several skin biopsies do show leukocytoclastic vasculitis and focal microvascular occlusion at all locations, and these were at various sites of the purpuric lesions. There was no IgA deposition. Given these findings, she was started on methylpred and anticoagulation. A peripancreatic lymph node biopsy was suggestive of, but not diagnostic of, monoclonal B-cell non-Hodgkin lymphoma, but the findings could also have been reactive. Culture of that lymph node in the abdomen was negative on all cultures like routine fungal and AFB plates. They MRA'd her abdomen and pelvis, which did not show any interesting findings. She was discharged on a prednisone taper, but the story doesn't end here. After improvement in her lab, she actually has recurrence of all these skin symptoms several months later, with once again rapid progression of purpuric lesions over several days. Now, this time they perform an emergent lymph node biopsy, which I've never seen done before, given again the concern about loss of limb. And they want to do this because they want to give her steroids because she responded last time and she was being tapered down. So they do this emergent lymph node biopsy and start the IV steroids. This biopsy this time shows necrotizing granulomatous inflammation without evidence of a lymphoproliferative disease. So given no clear answer, pathology was asked to perform an exam for IgG4 related disease, but the findings weren't even consistent with that, they said. So she was again started on the IV steroids and discharged with prednisone, and now there's a plan to actually start her on azathioprine. Now, I'll just ask for your final thoughts and discussion here. That's where the case ends. I do have a list of a differential for inflammatory retiform purpura that I just pasted from the dermatologist note. It looks like it came from a textbook or something like that. These dermatologists have a very fine differential for every derm finding, so I'm happy to share that with you all when we're done.
Oh, Andrew, I think this case is really, really tricky. The summary of the findings that we have, this is a hectic, severe disease, very, very aggressive. And I think it's now proven that the vasculitis framework is very, very helpful as the correct one because of the biopsy. And it's proven that this cannot be IgA vasculitis because the performance characteristics of IgA staining on that are very, very good. So at the end of the day, the question is, what is the best way to approach a normal complementemic IgA negative systemic vasculitis, and that just screams posse-immune or ANCA-associated disease. And the scream goes even louder when you see that you find evidence of granulomatous inflammation somewhere. You should pause for a moment because then the granulomatous inflammation is of a unique kind, and that's necrotizing granulomatous inflammation. which makes you wonder, hold on, have I been assuming that this is autoimmune incorrectly? And could this be malignancy or an infection? And I think that that's certainly very, very possible, but hard to prove. So yeah, I think the way I'd be operating is to say, to use one of our favorite facts, which is a thrombocytosis and a lymphoma are not incompatible, but less likely. And so it seems like this patient has to me, has an aggressive normal complementemic IgA negative vasculitis. And I'd probably be most worried about an ANCA negative ANCA vasculitis. Yeah, those are my reflex thoughts. Prof. Red?
I really have I have nothing to add. And it's just, I feel really sorry for this patient because like one of the worst states to be in is not know why you have what you have. It's like you can't put a firm label, but I also am happy for this patient because they are responding to therapy. I don't know if this is like a case where you send to like the NIH to do some kind of I feel like, Robbie, this is a disease this patient has that we just don't have a name for it. For example, like the pancreatitis that we never had a diagnosis for, and we always said was cryptogenic, just a fancy way of appeasing ourselves, ended up being IgG4 disease. I feel like the frame is beautiful. ANCA negative, IgA negative, normal complementemic, small vessel vasculitis. That's steroid responsive. But what it is, we just haven't identified it. But maybe in 10 years, Andrew, we have a diagnosis for it. I don't know, Robbie, like since you're so, yesterday during Alex's case, Robbie was saying Papa, and I wish I had said this.
Gotta give him context for that, Prof. Red.
I wish he said Papa.
I'm calling you Papa. Is that what
when
you
he said Papa was Stranger Things and 7? I think yeah, 7, right? On Stranger, that was her number, that the main actress, the protagonist.
I know you're not.
Someone confirm that, please. 11, yes. Gosh, I am so Robbie is like 51-1. Okay, 11. I knew something was off with that. Thank you. But you know, that's the only Papa I knew. So who knows, Robbie? I don't know. What would you do for this?
You know, Prof. Reds, I think that this does enter as a complete esoteria. And I will say that the only wisdom that I have to impart is from hanging out at rheumatology conference every Wednesday from 8 to 9. So we're so lucky that's on Zoom and I get to listen to them. And they have taught me about the sheer number of overlap syndromes that occur with ANCA disease. So you can have ANCA and GBM overlap. You can have ANCA and IgG4 disease overlap, and many other overlap syndromes. And you made this point yesterday. You're like, there is no, at Alex, there is no rheumatological diagnoses. They're all overlaps. So if I had to make the best guess that I could possibly make, I would suspect that this is some sort of ANCA IgG4 disease overlap based on the protein gap, based on the living in the mesentery. But I completely agree with you. I think this is an entity that I do not immediately recognize. And I cannot wait for the inevitable progress that happens in our fascinating field to then listen to this VMR on February someday, like 10 years from now, and be like, oh, this was a case of that. Because I'm sure given our progress in these domains, we'll probably have a better label on this, unless Andrew is a big surprise for us.
No surprises. This is just a Lisa Sanders case.
Well, you want to tell us what how your team was putting it together and where things stand?
Yeah, that's really where things stand. The rheumatologist note most recently just noted that they're going to treat it as a small vessel vasculitis. There wasn't any mention of like AAV negative disease. They're just calling it like a small vessel vasculitis that they want to treat in a steroid sparing manner, hence the prednisone plus the new azathioprine. So we'll see how she does. I'll let you know for sure if anything comes to light, but I think that they also feel that this may be an entity that they don't fully understand as well. And then just going back to the derm biopsy, because I thought it was really interesting and very, it seemed pretty kind of set for them. As I said, it looks like it came out of a textbook, the differential for retiform purpura. So they break it down into inflammatory versus non-inflammatory. So inflammatory, we touched on actually most of these. They list IgA vasculitis, mixed cryo, rheumatoid vasculitides, polyarteritis nodosa, and ANCA-associated vasculitis. And then for non-inflammatory, they describe systemic alteration and coagulation control, such as CNS deficiency or acquired and purpura fulminans or warfarin necrosis. They describe infection like angioinvasive organisms. They describe platelet dysfunction, such as in TTP, vascular coagulopathy, such as in APLS, calciphylaxis, malignancy, such as an intravascular B-cell lymphoma, and then drugs, as in levamisole and cocaine. So I'll list that. I thought it was really interesting. It's a very, very unique entity. Yeah, thanks for playing along. Very complicated case. Thanks for the teaching. It was fantastic.
Andrew, I think these cases are just, we talk about like unusual cases presented on VMR, and yes, we're still waiting for the day that an pneumonia or UTI is presented, and I think those are very educational. But I think I love that you're presenting a case that has no clear answer, and I think this is the extreme version of that. And it goes to show you that medicine is not some fully formed, complete field. We're constantly evolving and updating our knowledge. So I really appreciate you presenting this case. I think that you stretched us all and stretched Sarah, but somehow she managed to land the plane so well. Look at that board. It's full of incredible information. Thank you, Sarah. Prof Rez, any thoughts?
No, thank you so much. This was incredible.
All right, Maddie and Joy, take it away.
All right, yeah, so Joy and I did kind of some joint teaching points. So I'll start, Joy, if that's all right, and then I'll pass to you. And Sarah, just need to round of applause for you. That this could be like the most information recorded on the whiteboard. So incredible job. So jumping into the teaching points, so we started this case off with chronic abdominal pain, and a helpful kind of branch point you can use is this image positive or image negative. And in the imaging of this patient, we learned that the person had a volvulus. And an important question to ask with that is, what is the focal or the lead point of the pathology that led to the intestines twisting? And you need to kind of think quickly because you want to make sure that you alleviate any acute obstruction that's present. Right off at the beginning, we had this chronic constipation and crampy abdominal pain. And for the cramping nature, we asked, generally this means that there's a hollow, viscous being obstructed, whether that's the bowel or the biliary system. But we asked the question in the beginning that do these radiographic findings account for the symptoms? When we got more data that localized this to the mesentery, we learned that the mesentery is connective tissue with vessels that tethers the bowel. So you can think of, is there disease in the lymph nodes that spills over to the connective tissue, or the other way around, disease in the connective tissue that spills over into the lymph nodes? When we got the labs, we saw that there was thrombocytosis and a protein gap, the definition of that being the difference between the albumin and the total protein. And we learned a really helpful approach for thrombocytosis, which is thrombocytosis is usually a reactive problem, and it can be reactive inflammatory or reactive non-inflammatory. So for the reactive inflammatory bucket, you can think of infectious, autoimmune, and malignant causes. For non-inflammatory, you can think of disorders of hemoglobin. So whether that's acute anemia, a rebound disorder, or functional asplenia. So for example, sickle cell disease or celiac disease. The presence of the protein gap alongside the thrombocytosis made us consider more of the reactive inflammatory processes. And we again learned that there was bowel wall edema, which we translated into bowel wall thickening. And for that differential, you want to consider infectious causes, inflammatory like IBD, infiltrative like IgG4, sarcoid amyloid, and ischemic. We talked about some clues for IgG4 disease, including mesenteritis, eosinophilia, and elevated IgE. So I'll now pass the mic to Joy to take over the second half of teaching points.
Yeah, so thank you so much, Andrew, for bringing us this really awesome case. And I'm sorry, my connection earlier was so bad. I'm just sorry. So Reza and Ravi, thank you for dropping all these amazing pearls. So Reza told us that in in this case of like a really complicated case, there are features in the presentation that has to be explained in the final management of the patient. And yeah, so in this case, the palpable purpura has to be explained. We have to think about if it were non-blanching or blanching, and if it were non-blanching, it would be more leaning towards like coagulopathy, extravasation, more of towards a more complicated hematologic problem, and looking into the coagulation profile of the patient, such as INR, PTT, and PT, would be helpful. And of course, given the presentation here of skin, GI symptoms, and the patient predominantly have, so we think of the vasculitis diseases, and then we go on to think, obviously, classify them as to their sizes. And Reza told us that the small vessel vasculitis, you can almost predict that it would be a small vessel vasculitis if you see lower extremity rashes that could, the small vessels could easily break with the gravity pressure there. So if they're already inflamed and highly leaky, so. And also with, I think it was Rabi who told us that when we're confronted with a glomerulonephritis situation, we have to obviously think of infectious or inflammatory, like rule out infectious first. This is like a general theme in medicine, like go first with something that you can do something quickly. So rule out infectious mimic. So with infectious mimic, you could say that they are infectious mimics because they have normal complements. They don't really yeah, they as much as consume complements as much as we would see with inflammatory syndromes that causes glomerulonephritis / vasculitis, such as with anti-GBM, and IgA vasculitis, which was like a top of consideration here, given the GI, predominantly GI and skin findings of the patient. And we also thought of like it could be IgG4 syndrome, inflammatory syndrome, but then we saw that they have normal complements, and this doesn't quite fit if they're already this way progressed or in their disease condition. So that Rabi told us that. And so this whole thing, obviously we need to think of the patient here. We need to like save their kidneys, right? Like Reza told us that this warrants a steroid to save, their kidneys in this case. So, and then, so we found out that they did have the treatment team here, which was a lot of teams involved, like the of course medicine people and the derm, where treating this as with the findings of normal complement and negative IgG or IgA, the consideration was like could possibly be a palsy vasculitis, like the P-ANCA, C-ANCA, and it did respond with steroids, so they went on that, and it was they also combined it with azathioprine. So, and the derm did the biopsy, obviously to hopefully give the patient a definitive diagnosis here, but the biopsy did tell us that they have retiform purpura, and that could be inflammatory Etiology, such as like a cryo, under a whole list of those, and a non, or could be a non-inflammatory, such as an ANCA vasculitis. But this whole thing also informs us that in real life, there is no such thing as a pure syndrome, like an ANCA, purely ANCA syndromes. Ravi and Reza told us that it usually is like you're seeing a combination of ANCA or a GBM overlaps. So, yeah. Hope you learned something.
Oh my gosh, Joy, I can't believe that you had the task of having to summarize the teaching from this case. I don't know if there's really anything concrete that we can recap apart from just how challenging it was. And really appreciate you putting this together. I can't imagine how I would feel if I had to do this for my first ever teaching points. I don't know if there's been a more complicated case presented on VMR, and I think it's just such a testament to what you all are doing. You know, this is Sarah's first time scribing at 1,000,000 miles an hour, and your first time teaching with 1,000,000 pearls an hour, but yet no cohesive story to summarize it with. There's no final answer. There's no final theme. So thank you so much for walking us through that, and appreciate your boldness and your bravery to be able to continue to power through it despite how complex this case was. So thank you all. Wanted to say that tomorrow is a very, very special day for CP Solvers because we get to celebrate our CP Solvers Brazilian contingency. So join us if you can tomorrow. Rafa, Deborah is here. Laura will be joining. I forget who, Amanda is going to be there. And I'm missing one other person. Oh, Marcella. So all 5 of them will be there tomorrow. And we're just going to celebrate Brazil, medicine in Brazil, and celebrate these wonderful people. So it's that tomorrow at 12 p.m. Pacific, 3 p.m. Eastern. If you can join us, that would be amazing to honor them and get to know Brazil a little bit. All right, peace. See y'all.